Hi guys, Dr. Garima here, and it's like 11:05 p.m. out here, about to go to sleep. And today I just messaged in my enrolled candidates group as to what doubts they have, where they are finding any trouble because it's just 1 month remaining for the exam, and they give me a certain set of questions. Uh, yeah, I tried to go YouTube live, but somehow the webcam wasn't coming, so I stopped and I'm just recording it and then uploading it like my any other video. So yeah, I'm actually very outdated with how to go YouTube live. I'm trying, but the webcam is just not working with it somehow. So yeah, that about it. I'll just pause this video for a second. Yeah, so I'm back. I was just leaving a message on the enrolled candidates group. So anyways, we have like 32 of the candidates appearing here, and like I was telling all of them, be positive and just keep on following the study pattern and study with a lot of faith and sincerity. And your hard work would be answered in the way which is best possible, suited for you, and decided by God. So, anyways, let me try and answer the queries. Uh, One of the candidates has said that they feel difficulty in answering the TMJ questions. TMJ is a vast subject, and mostly the questions on TMJ will be asked either with splint to give in what condition. For that, I've already shot a good 30-minute video and uploaded it, and it's the most simplest, easy to understand video that you will get ever. Honestly, not boasting because I've done it, because even that time, even I had this brain, what do you say, thing happening, and I just shot that video, and I think it has over 1,000 views by now, and everybody has appreciated how easy it is to understand. So, with Splint to give in the TMJ scenario, you'll get that. The other questions which might come on TMJ is related to the injuries of TMJ and where the mandible would be deviated. And one of the candidate was also confused. See, I understand as a dental graduate, when you're studying and even when you're in internship, you rarely get to see a TMJ problem. Uh, so when you don't see actually practically, it's very difficult for you to visualize theoretically as to what things to expect, and whatever theory is mentioned, it has to relate practically to. But if I can just try and ease out the scene for you, let's try this scenario. For example, so this is my right side, okay? Example, I have an injury on the TMJ out on this side, and say this side has got ankylosed. Hmm? The question will ask you which side the mandible will deviate while opening. And most of the people answer on the left side. It's wrong. I don't know why you think it will deviate on the left side. Because probably you think that because the left side is functional, when you'll open the mouth, it will go left. No. Any ankylosis or any problem in opening the mouth of the TMJ on the affected side, the mandible will deviate on that side. I'll tell you how. Now, so for example, this right side is injured. So basically this is locked, okay, this side. This side has developed well. This side has grown well. The bone and the condyle of this side has grown, but this side has not. So this side will become longer, and when we'll try to open the mouth, like it will be like this. You see, this side is the affected, and if suppose I'm opening the mouth because this side is developed and this side is stuck, where did the mandible deviate? On the affected side, right? You understanding my point? So don't think because this side is well developed, the mandible is going to deviate. So this is called as the ipsilateral side and this is the contralateral side, okay? So whenever there is a fracture of a mandible, it is stuck, it is ankylosed, then when you open the mandible, it's going to deviate on this side, the affected side basically. So read the question properly, what it is asking, which side the mandible will deviate. Get my point? So once you understand this concept, there is one another condition where the mandible will deviate on the contralateral side. I don't remember that condition at the moment, but it's given in your basic oral surgery textbook, you know. So if you want, let's just Google it, you know. But when I'll go to Google it, I guess as soon as I will start typing, this can get paused. So, okay, let me not Google it at the moment. Let me just talk and finish off the majority of the queries. Second question was restorative material selection topic puzzles me. Okay, so there are a few questions which says that suppose a patient is having schizophrenia or dementia or is an old person with Parkinson's and he's having anterior and posterior class 5 cavities. So which material you're going to use? See, you have to understand that in such patients, yeah, I'm having a bit of a shoulder pain, so I'm pressing it. Uh, in such questions where drilling poses a difficulty and yet you have to restore it. For the posterior teeth, when it's a not carious lesion, okay, it's a class 5 erosion or abrasion defect or a mildly carious lesion, like not like rampant caries, like over a period of years the caries has developed, that kind of a lesion. In posterior teeth, it will always be RMGIC, resin modified GIC. Understood? Why? Firstly, class 5 is an area where achieving isolation is very important. And if the patient is old or is moving constantly involuntary, like Parkinson's, or is having dementia, and you don't have much time, because the patient can turn restless at any point of time. And composite requires like thorough, it's a very technique sensitive procedure, so thorough drying and it takes time. Composite takes time, of course. So RMGIC is the best option because all you have to do is just drill, or even if you don't drill, you can use the ART technique, that is atraumatic restorative technique, and you can just spoon excavate the lesion. And plus, it has chemical bonding to the tooth structure, right? GIC is man-made dentine. Composite is man-made enamel. So you can always do RMGIC. It's faster, it sticks, it releases fluoride, so that is taken care of. And it looks nice, although not so much of shiny glossiness like a composite. But in posterior region, in class 5 areas, you don't need that aesthetic part. So RMGIC is the answer. If RMGIC is not given, you can even choose normal GIC as the option. Anteriorly, because it falls in an aesthetic zone, the area is more easily controlled of the saliva. It's easier to achieve isolation in the anterior region. You can go with composite. RMGIC is not a wrong option at all, but if composite is given, then I will choose composite first. I hope this is clear and it's not confusing to you anymore. NSAID topic still puzzles. Why? I don't know what problems you have with the NSAID topics. Yeah, there are certain things that you will have to remember. For example, which is the safest. So, see, you have to read the question properly. Paracetamol is not an NSAID. Understood? So, if the question is asking which is the safest NSAID and they give naproxen and paracetamol and you choose paracetamol, then you are wrong. They have asked you about NSAID. NSAID means non-steroidal anti-inflammatory drugs. Paracetamol is not that. It doesn't come under that classification. So don't choose that. But if the question is asking which is the safest painkiller and they give the options of brufen, paracetamol, etc., especially in a pregnant woman, you can choose paracetamol then. Then there'll be a question on suppose the patient is having severe gastritis and they'll give which one you will give, ibuprofen or celecoxib. Then TG mentions celecoxib as a better option, right? See, the more specific medicine is, the dose will be less and the side effects will be less. Understand this point. That is why certain steroids have such less dose, like they are in milligrams, because they're very specific. And yet there are certain medicines, for example, paracetamol, which like acts on a general pathway. It will have a big dose. It runs into up to 400 milligrams or up to 1 gram also. So the more specific a medicine, the lesser would be the dose of it because it will go and act specifically on those kind of receptors. And the more less dose, the more specific, the less side effects. Always remember this point, okay? So I hope this is clear. It's easy. You just have to understand the mechanism and read the keyword of the question properly. Once you understand the keyword, it's a very specific thing. It's as good as me walking into kitchen and there are like thousands of different things kept, and I'm very specific. Like for example, I want salt where it is kept. But if I keep on saying, okay, I want that spice which is looks like a white in color, then I'll keep on searching for 10 spices which are white in color and it smells like this and that. No, so be specific. Understand the keyword. So I hope you're getting my point, right? Next question is RPD. Removable partial denture is a huge topic. Now, again, I understand as a basic dental graduate, especially from the Asian countries, you may not even have seen a cast partial denture in your internship. Forget about doing one. You mostly do that when you're a postgraduate, and usually interns and postgraduates like they interact, but they're not like case specific interaction is not happening. I barely saw interns assisting postgraduate students with their cases because if they did, then they would realize what all new things are being done, which were not taught in general dentistry. But as a dentist, you're expected to know them, and as a dentist who's going to practice in Australia, you're supposed to know it. So, removable partial denture is not just the acrylic one. It encompasses the basic acrylic one, which you have made, a flexible acrylic denture, and a cast partial denture. Most of the problems arise in the cast partial denture because you haven't done one. So, neither have I done one for that matter. It's just me reading that book, Stewart, has made me understood a lot of concepts because you have to imagine so many things because you have not done it. Uh, that is something which you'll have to study. But majorly the questions which are asked in RPD first is Kennedy's classification. Please mug up. You know, there is no excuse for not knowing that. They have defined the classification very well. Study the classification, study its modifications. That is basic dentistry. I cannot teach you that. That you have to go and open your book. Next is understanding the clasps, the different type of clasps, and the rest seat that is given. I know we have not done cast partial dentures, so it's always difficulty in visualizing how a clasp is going to look like. Please Google. The kind of questions that would be asked in clasp is first on the rest seat as to how it should be. And by now you should know the rest seat is always concave, not flat, and it's directed towards the center of the tooth. It's like a triangle with the apex at the center of the tooth and base outside. The rest seat is given as a support. Now, if it's a normal tooth, you drill and make that with a round shaped burr, size 6 or 8. If there is already a restoration on it, then you give an inlay. You don't give a crown. Okay, remember that. Crown is too destructive over the tooth, so you give an inlay. I'm just pausing. I have to on the charger. Yeah, hi. So, yeah, what I was saying was if there is a restoration present, then you will always give an inlay over it. I understand as a graduate, you may not even have done an inlay, but in an inlay, you can actually decide the position of the rest seat and you can make it in the inlay restoration itself. You don't have to drill it again. Crown is not advisable because you're further destroying the tooth and it's difficult to give a rest seat on a preformed zirconia crown. You understand? So that is about the rest seat. Study more about the eye bar. That's the KPI system. Crawl. Then study about the circumferential class, the different types of clasp, embrasure clasp. Now, one question will be wrought clasp and the cast clasp. The cast clasp is what? You make the design with the wax, you put it in a furnace, the wax melts, and a cast kind of a material comes which is very thick. Wrought is something which you can bend easily. It is like your wire, example, your 21 or 19 gauge wire, orthodontic wire, but even flexible than that. So wrought wire is very flexible, so you can bend it easily and it can engage in your undercuts, but then it can also break very easily. You understand? So wrought wire is something which you will give if you have to really bend the wire a lot so that it's not visible in the aesthetic zone, or it's an urgency and there is no wire and then you have to give a wire, then wrought wire. Otherwise, you will always give a cast wire. You understand? Cast metal which is manufactured in the lab. So read more on it so you will understand what I'm trying to say. I know this is a bit difficult topic, but it can be mastered if you study well. And if you have further questions to understand, you must be having some or the other prosthodontic friend. Please call them and ask your doubt. Sometimes the postgraduate people who are your friends of the field that you're not trying to understand can help you. My own brother is a prosthodontist, and when I was studying, I also called him and asked him to clarify some of my doubts, which he did it. So there is no shame in asking for help of certain topics which you don't understand in spite of reading the theory. So, but nowadays, slideshare.net is there, and there's so many PowerPoint presentations available. Take the effort, go through at least 5 or 6 of those presentations, see pictures on Google, you'll get a basic idea. And that basic idea is enough for ADC exams. They are not actually asking you to manufacture something and show it to them. Understood? So the next question is on fluoride application, which one to apply in which condition. See, therapeutic guidelines has clearly stated that table which you have to mug up. Like I have mentioned, write that table, stick it on your dashboard and memorize it daily. But an easier way to remember, I'll tell you, after the age of 6 years, the child actually learns to spit out properly. So you can use a fluoridated toothpaste. Whenever a question is asking you, what is the best method after the age of 6 years to, give fluoride? If the option is there to use a fluoridated toothpaste of 1000 or 1500 grams twice a day or more than twice a day, choose that option. Make that option the first priority. The second option will be using 5000 ppm twice a day. More frequent brushing with 1000 ppm is way better than brushing twice by 5000 ppm. Understand this basic point. Because the more you brush, the more your teeth are clean. It's not the fluoride which is getting absorbed. It is a basic common sense. The more I'll rinse my mouth, the more cleaner it will be, rather than me brushing only twice. You understand? So both the options are correct, and that's why the therapeutic guidelines have mentioned both. But if both the options are given in your exam, probably it's an unmarked question because both the answers are right. But don't break your head into what I should choose. You can choose either, but I would give the first priority to the 1000 ppm one. You understand? Because it's also easily available. Try going out in the market and searching for a 5000 ppm toothpaste. Would you find one easily like in any supermarket? Even pharmacy for that matter. But you'll easily find 1000 or 1500 ppm of toothpaste. So use common sense basically. Sometimes in many clinical scenarios, even theoretically, it looks something good, but is it actually feasible? It's like me saying HBSS is the best solution for avulsion, but if suppose today in my own building, if a child falls and they call me that doctor, my child has fallen and tooth has come out, what I will tell them, search for HBSS solution. No, I'll just say take milk and put it. So though milk is on the second priority and lab tested HBSS is the best, what is more common sense and which is more reasonable to do at which is generally available? You have to choose that answer. That is called as clinical presence of mind. ADC is not checking your theory. Put that in your head. It is checking your presence of mind, how you as a clinician is going to tackle a particular situation. You understand? Theory is already tested. They are not testing your dental theory. You're not giving a exam to pass your graduation. You're giving a licensing exam so that you are deemed fit to practice in another country, assuming you have the clinical presence of mind. If you solve the question with this kind of attitude, you will 100% clear your exam. But if you will be hell bent on choosing the right answer, which looks very ideal and theoretical, you're not going to clear the exam. And that is why the passing percentage is so low, because most of the candidates choose the theoretical answer. And of course, they will give you that option. They want to check the presence of mind. And that's why I love ADC Part 1 exam, because you need to know as a clinician what to do, which may not be ideal according to the theory, but then you are not living in an ideal world. You are living in this world, and you have to choose something which is possible in this world. You understand? So yeah, that's about that. Again, partial denture. I told about partial. Yeah, one more thing about partial denture which I wanted to say. There was also a doubt by one of the candidates. There was a question where a patient had few missing teeth and it was periodontally compromised. So, which is the best material to give him for removal partial denture? And the option was acrylic and cast partial denture, and many of the candidates chose cast partial denture. Cast partial denture is more stable, yes. It is more expensive, yes. Now you have to understand, if already few teeth are missing and the condition is periodontally compromised, you will be anticipating further loss of teeth. And you also cannot give pressure on other teeth for support, which a cast partial denture does, because it has clasps, it has occlusal rests, which does give stress to the remaining teeth. And yet people have chosen cast partial denture, in which you cannot add an extra tooth if one of the tooth falls off in near future. And the reason being, but doctor, that is the more better option. Theoretically, right? Practically, is it possible? Is it wise to give a cast partial denture to such a patient? No, you have to give an acrylic denture in which you can add the teeth, which will not turn out to be expensive also. Plus, an acrylic denture will take more support from the tissues than the tooth. And you can always just give a wrought wire clasp, a C clasp for the retention. You get my point? So once I explain this, then the candidate understands. But this is common sense, okay? And you don't want to keep on increasing the cost of the patient by giving him a cast partial denture in already a periodontally compromised dentition. Yes, if the patient had very good bone and there was only one tooth missing, and then you had to give a cast partial denture or two teeth missing, for example, and periodontally the dentition was very sound, there was no bone loss, you don't anticipate any further loss of teeth, then cast partial denture becomes a good choice. Understand the scenario, and then the candidates would compare, but doctor, in that question you chose cast partial and this acrylic, why? See the scenario, it's a different, every patient is different. How do you expect the same answer for all the scenarios? It is not possible, right? That's why read the question, think like a clinician. Understood? So yeah, pretty much these were the doubts. I hope this has helped. If any more doubts, just message. I'm trying to simplify the doubts. And actually, it's more on the lack of the knowledge than actually doubt in the questions, because the reason you feel more confident with other subjects is because you have studied them more better than these subjects. And it's not your fault, because I understand as a basic dental graduate, the way studies are there and the kind of questions ADC is asking, somewhere they don't overlap. So there is a certain gap in the knowledge in certain subjects which ADC expects you to know, but when you are taught, you're not taught them. So you're on your own on this. But also understand that you're not the only one who's on your own in this. The rest of the candidates who are appearing with you are also on their own with that. So everybody is taking that effort to understand these kind of questions. So it's okay. Uh, Learn as much as you can, and the more you will learn, the better clinician you'll become, and better you'll be able to solve the questions in the exam. So I hope this is clear. I hope this was helpful. And yeah, I have consolidated the ADC written part one and part two WhatsApp groups. Over that, we have like almost 2,000 candidates now. You can also leave your doubts there, or you can leave in the Facebook comment section, or this video comment section itself you can leave. Since the exam is coming next week, I'll try and solve as many doubts as possible of all of you all. Be very specific in asking your doubts so I know exactly what to answer. Don't give me a vague topic. I have problem in this, like that. I don't know what is your exact problem then. So give me very specific scenario or very specific thing that you are unable to understand, and then I can answer. So best of luck. Just a month left for your exam. Very life defining moment. It can change the course of your life. Be very grateful that you have been given this opportunity. Be very thankful that you have the resources that you can study, and be very supportive to those people who are supporting you. All this peace and harmony will make you more relaxed and will make you study in a more better way, and it will make you absorb whatever you have studied, because that peace and harmony will make you focus and will function at its best when you're giving the exam. Always remember, it's the extra support, care, harmony, peace, tranquility, intelligence, alertness, that is what defines how you perform in the exam. All right.